Good afternoon. Welcome to this session. My name is Roxana Moran from New York, Mount Sinai Hospital, treating complex CAD indications with sirolimus-coated balloon, evidence and performance. The session is sponsored by Concept Medical. I'm here with our anchor person, Professor Abazaid from Sao Paulo. And we are going to have a fantastic session with an excellent faculty and discussants and our keynote speaker, who would be Dr. Aloik Finn. We have Alfonso Lalassi, Cohen Toin, Praveen Chandra to my right, and Danielle Jones, and hopefully Azim Latib if he joins us. Our session will be totally dedicated to sirolimus-coated balloons, and we're going to talk about some exciting clinical evidence regarding safety and efficacy, the performance of this MagicTouch sirolimus-coated balloon in complex setting, why it could be a good choice, and I think we're really awaiting lots and lots of clinical trials, and gaining insight into some of these new approaches of using sirolimus-coated balloons in treatment of bifurcation and de-novo lesions, and even some of the trial updates. So we're really, really looking forward to this, and I'll turn this over to Professor Abazaid.
Thank you so much, Roxana. This was a wonderful introduction. We want to make this session very interactive. And as you can see in the program, it's going to be less talks and more examples, more cases. We want to see the performance of these balloons, not only acutely, but also at long term. So I'm sure that some of these experienced physicians will be able to share their experience with you in a case-based session. I think, after lunch, it's always nice to have something that keeps you alert. So I'll start with Dan. Dan Jones is going to be the first presenter, complex case presentation with sirolimus-coated balloon. Welcome.
Okay, thank you for the introduction and for the opportunity to speak. I'm Dan Jones, a consultant cardiologist from Barts in London, and I'm going to share with you a few cases that we've used we've recruited into the Transform 2 trial, which is comparing a MagicTouch sirolimus balloon versus a stent, and I'm going to show 3 cases over the next 7 minutes, quick fire to keep you awake after lunch. I've got no potential conflict of interest. So the first case, 35-year-old gentleman, history of angina, assessed in a rapid access chest pain clinic with a CT, which demonstrated disease in the LAD and the right coronary artery, but he presented with unstable angina prior to a planned angiogram. His first intervention, he was on 2 anti-anginals. This was his CT scan prior to invasive angiography. We can see that there's some disease in the proximal LAD, which is probably moderate with a fleck of calcium. Circ is relatively unobstructed, and then we can see that the money's in the right coronary artery with a long length of disease, mixed plaque with quite a critical stenosis in the mid-vessel. Of note, the coronary ostia were normal, so we could, in terms of normal position, so we consider normal diagnostic catheters. This is the invasive angiogram, so the left-sided first. You can see that the circ is relatively free of disease. The LAD scan in the cranial view has a moderate stenosis in that proximal vessel, and we can probably appreciate that the right coronary artery is backfilling from a retrograde collateral from the LAD. And then on an off-mag 2020 appearance, we can see that this does backfill to the mid-right coronary. So we're expecting at least a subtotal or occluded right coronary. This is within the right coronary artery, which looks similar to the CT, so a long length of disease with a critical subtotal occlusion in the mid-vessel. But there is antegrade TIMI-free flow. So we proceeded to wire. Wasn't the most straightforward, required a hydrophilic wire and a corsair, but it was trapped out. And then we sequentially pre-dilated with a 2 and then a 2.5 semi-compliant balloon. This was how the vessel looked at this point. He had been consented to the Transform 2 trial. I had been hoping to randomise him. At this stage, it's not looking particularly promising. This is an extremely long length of apparent disease. But with further lesion preparation, so we further pre-dilated with a sequential 3.0 18 NC and then a 3.15 cutting balloon, and we're much happier with the angiographic appearance at this stage. We had a further pre-dill with a 3.5 18, and then the patient was randomised and underwent treatment with a 3.5 40 MagicTouch sirolimus-coated balloon. And this was then the final angiographic result, which we were pretty happy with. at this stage. 3 months later, he came for a pressure wire of the LAD, just in terms of complete revascularization. That was negative, but again, we were happy with what we were deemed to be an excellent angiographic result in the right coronary artery, completely metal-free, and he remains asymptomatic now nearly 12 months after the procedure. Second case. So this gentleman, this isn't a Transform 2 trial, but this is a 43-year-old gentleman who had a previous intervention to the LAD 6 months prior to this presentation, had 2 drug-eluting stents to the proximal mid-LAD, but he then presented with a recurrence of symptoms and 10% anterior ischemia on a perfusion scan. And in view of persistent symptoms despite medical therapy, had a recath. Now here's the series of diagnostic pictures with a guide catheter. You can appreciate there's some moderate stenosis in the circumflex, but again the problem appears to be in the LAD with an occlusion within the previous stented segment in the mid vessel. This is more apparent on the areocranial shot, where we can see that there is a complete occlusion. Again, we proceeded to perform PCI and fix this percutaneously. It required a Corsair, a cyan blue or workhorse wire wouldn't cross, but we were successful with the Pilot 200. The vessel was sequentially pre-dilated with the 2.0 semi-compliant balloon, leaving this result where we can appreciate the restenosis within the stent. IVUS was performed, which demonstrated a 50% lesion on the distal end of the stent, but the stent itself both had significant in-stent restenosis, but also was underexpanded in both the mid and proximal vessel. We therefore proceeded, based upon the IVUS, to predilate with a 3.0 NC, 3.5 cutting balloon to cut into the neointimal proliferation, and a 4.0 NC at the top end. This was then the angiographic appearance, which we were much happier with. So therefore, we proceeded to finish the job with a 325 sirolimus balloon off the distal end to cover the distal stenosis, and then recoat the layer of stent with a 325 and then a 3.5/25 sirolimus balloon, leaving this final result, which looked good on IVUS, so we were happy with the distal end of the stent. Again, this patient came back for a staged assessment of the circumflex 3 months later, and here we can again appreciate positive sort of remodeling within the LAD and distal vessel, which from our perspective, we were very happy with the angiographic result 3 months after the intervention. Final case. Again, young patient, under 50. We see a lot of these at Barts. 46, again, history of stable angina, investigated with the CT, which is first line under apoplectic chest pain clinic, and was CCS3 on 2 anti-anginals, no previous intervention. Here the CT scan demonstrated a moderate length diffuse disease in the right coronary, relatively unobstructed circ, but again the money is in the LAD, where we can see this calcific plaque in the proximal vessel, and then this critical or severe stenosis just proximal to the LAD diagonal bifurcation. On angiography, again, the right coronary is just moderately diffusely diseased, but the left-sided pictures pretty much confirm the CT with this critical severe stenosis within the proximal vessel just prior to what is a large diagonal. So and this just confirms that in the areocranial to remove any foreshortening. So we wired both vessels, pre-dilated with a 2 and then a 2.5 semi-compliant balloon. And here we can see the improvement, and to then allow for intravascular imaging. This will be the quickest OCT you ever see. I'm not going to question you on it, but we could see that there is still a need to expand the lumen area further, which was apparent angiographically, but we could assess for vessel sizing and lesion characteristics, and we could already see some early dissection with the small balloons. We therefore prepared the vessel further with a 3.18 non-compliant, and then a 3.15 cutting balloon, and then a 3.5/18 non-compliant sized off the OCT. And this was then our this was our angiographic appearance before we made the decision to randomise in the trial to either a stent or a DCB. Quite happy to do that with a limited, the type A/B dissection, and therefore we performed the 3.5/25 sirolimus coated MagicTouch balloon to the proximal LAD, leaving this final result. in the proximal vessel, where we can see that there is a residual dissection, hence the name of the case. However, there's no dye hold-up, TIMI3 flow, good flow in the diagonal and LAD. So we left this, the patient was well and was discharged the same evening. 3 months later, we brought him back for a CT scan to assess the healing of the dissection. That's just part of our practice currently, and we could appreciate on the left-hand side this severe stenosis just proximal to the diagonal bifurcation. But the follow-up CT, although you can still appreciate this non-obstructive calcific plaque, that there's been an excellent remodelling of that mid-LAD just proximal to the diagonal, and this patient again has been seen at 12 months and is asymptomatic. And that's my 3 cases. Thank you for listening.
Thank you so much, Dan. This was very encouraging to see these very complex cases, such good results. And what you did for this presentation, that's exactly what we need to be seeing more and more with DCB. Because we can sometimes struggle to have the best acute result, but how it's sustained over time. So this is one of the big costs. Yeah, the remodeling is a fact. Sometimes you are treating a complex coronary, there is spasm associated, that the acute results are not so brilliant. And as you showed, some cases are really more relaxed after a few months. So my question before the audience gets more encouraged to ask questions. And again, if you are not shy, go to the microphone. If you are shy, you can send us questions. Roxana is going to read them. I saw that in those 3 cases you used image. I was OCT. Is that something that it's 100% required for DCB? And remember, not everybody in this audience will have very liberal use of imaging. And if not, when do you think it's mandatory?
Yeah, I mean, I think importantly, I use a lot of imaging generally, and I would use it a lot to characterise the lesions and to prior to having leaving nothing behind and just performing a DCB. I don't think it's mandatory. I think that in the first case I didn't actually use imaging, but I used CT, and the CT beforehand had told me what I needed to know about the calcium burden and the ability to probably get away with just a DCB, assuming I had a good angiographic. All of the characteristics for success for DCB are still angiographic. I think imaging is very helpful to give you an idea as to whether you think you're likely to be able to perform a DCB, and it can be helpful after pre-dilatation to see if you can see non-angiographic dissection. And I think dissection is important to have good healing and modifying the stenosis. But I don't think it's mandatory if you have limited access, but I think it is helpful.
Quick question.
So the last case, like it's more a proximal LAD lesion. And this is a friend who asked me this question an hour ago, that if this, for example, this patient presents with stent thrombosis and he dies, can we defend ourselves that we did the right thing for the patient rather than stenting him?
Well, I mean, I guess I guess from your question, I mean, the last case, I agree that there isn't currently the evidence in a large vessel de-novo lesion to purely perform a DCB. The evidence is an accumulating base, and the last patient was part of the Transform 2 trial where you're randomized to either a DCB or a stent in a large vessel. So the patients agreed to be part of a research trial. We need to generate evidence, and you can safely put in a stent if needed as part of that trial if you meet certain criteria in terms of stenosis or dissection. In that case, that's a dissection that we would quite happily leave, and the patient did very well. I mean, I think the whole purpose of a DCB is to avoid the stent. And I guess you meant the acute vessel closure, but obviously there is no metal to have a stent thrombosis, which arguably in the next 10 years, a 45-year-old is not going to have a stent thrombosis after a DCB, but might have done if you put in a stent. So that would be one of the benefits, if that helps answer the question.
Just taking this case, it's really concerning. You live in a dissection, and the proximal LAD could be a proximal vessel RCA. Do you recommend any difference in terms of anticoagulation, antithrombotic therapy, maybe to leave 2B3A for 12 hours, something like that? Do you recommend that?
No. I mean, we haven't. So it's a good question, but there isn't any again, from a trial perspective, there's no sort of protocol mandated need for GPD3A. We don't normally use it clinically. I think the important thing, at angiography, and if it is a type A or type B dissection, I appreciate it's a proximal vessel, but if the true lumen is significantly and much bigger than the false lumen, then the dissection will heal. And we haven't seen any acute vessel closure in the patients that we've studied, and I think the event rates in the trials are also very low. So I know it's a slight change in practice, but I think that sort of dissection will heal. You could use imaging if you're really concerned about the extent of the dissection, and then make a decision at that stage. But in that case, we didn't do so.
Thank you so much, Dan. This is a great discussion, but we have to move. And now it's my pleasure to invite Alfonso, who will perhaps tell us a little bit about the GINGER trial and show a case example.
Yes, thank you very much for the introduction. It's a great pleasure to be here. I'm Alfonso Ielasi. I'm an interventional cardiologist based in Milan, Italy. No conflict of interest to declare. So GINGER trial is a prospective single-arm study whose aim is to assess the performance of the MagicTouch sirolimus coated balloon in complex lesions. And as I said, the aim is to assess the angiographic performance of this device. Very few exclusion criteria were defined, so the use of this device was very liberal, and even hybrid DS and DCB approach is allowed, as well as the treatment of heavily calcified lesions. This is an Italian study. 110 patients were already enrolled, and we are going to finalize the 9-month angiographic follow-up within the next June. Primary endpoint of the study is late lumen loss in the sirolimus coated treated segment at 9 months angio follow-up, and the mean net lumen diameter gain at the CSB treated segment at 9 months follow-up. So I would like to share with you the case of a 68-year-old male, diabetics. He already underwent PCI because of chronic coronary syndrome with stent positioning on the left main, LAD, and left circ. The RCA was occluded and non-dominant, while several distal lesions were left on the left circ, dominant left circ, first and second obtuse marginal. After a few months, the index procedure, the patient still complained effort angina. That's why he underwent angiographic control. This is the baseline angiography. So the result of the previous PCI on the left main and on the LAD and the proximal left circ is fine, I would say. And as you can see, there is a lot of calcium on the left system, particularly on the left circ, with stenosis on the distal left circ, proximal second obtuse marginal, and proximal first obtuse marginal. So this case was performed live for a course, and the patient was enrolled in the GINGER trial. So the target for this procedure was to perform intracoronary imaging in order to better assess the calcium on the 3 target lesions. Then, of course, as for every DCB PCI, aggressive pre-deal with the aim to obtain a diameter stenosis less than 30% and no malignant coronary dissection. And as I told you before, DCB as intention on the 3 target lesions. So the first step was to perform OCT, but the probe didn't cross, particularly on the second obtuse marginal. So we tried to predilate with a 2.25 NC balloon, and as you can see, after inflation, the balloon ruptured. So we performed an unintentional granuloplasty, I would say. So the second attempt with a 2.5 NC inflated at 20 atmospheres was successful. The balloon expanded well, but probably not fully. So we have decided to perform EVL also using a 2.5 C2 shockwave balloon, 8 cycles, 10 pulses. The delivery of the balloon was very difficult, so we have needed to advance a guiding extension catheter up to the mid-segment of the left circ, but the balloon expanded very well. This is the angiographic result after lesion preparation and also the OCT run. As you can see, the MLA was between 144 to 30 millimeters square at the target segment on the distal left circ. So we have pre-dilated, again, using a 2.75 millimeter balloon inflated at 24 atmospheres on the distal left circ, and then a 2.75 30 mm MagicTouch was delivered and inflated successfully, as you can see with the result you can appreciate on the right part of the slide. Then we moved to the second obtuse marginal, so pre-dilatation using an NC balloon 2.5 at 24 atmospheres, and then MagicTouch 2.5 30 millimeter at 8 atmospheres for 60 seconds, and the results in terms of angiography was more than acceptable considering the lesion we are facing with. So we moved to the first obtuse marginal predil, and then inflation of a 2.25 20 millimeter MagicTouch inflated at 8 atmospheres, again for around 60 seconds. This is the final angiographic result in two orthogonal views, and this is the functional assessment of the lesions. So the MUFR was performed, and as you can see, the values are negative for all the three lesions. So we ended the procedure. The patient was asymptomatic, mild increase of ultra-sensitive troponin E, no electrocardiographic modification. The patient was discharged on day 2 after PCI and scheduled as per protocol indication for 9 months coronary angiography. So the patient came back for coronary angiography follow-up, and this is the result at 9 months. As you can see, the target lesion, particularly on the left circ, is well dilated, no recoil, no restenosis, and similar result are appreciated also on the first and second obtuse marginals, and even the functional assessment, non-invasive functional assessment, was more than acceptable, I would say, with 3 negative values on the 3 target lesions. Again, the final angiogram at index procedure in the upper part of the slide, and below the 9-month angiographic follow-up with all the values by QCA released at the right panel of the slide. So in conclusions, GINGER trial will provide soon, I hope, data on the angiographic performance of MagicTouch in complex coronary artery disease. A head-to-head comparison of this sirolimus coated balloon alone or in combination with DS versus a DS-only strategy in complex lesion is, of course, needed. Thank you very much for your attention.
Yeah. So we have one more. I think you're waiting to ask a question, and then we move to the next. Then we're going to stop a little bit for more questions.
There is only one small question regarding the setting of the marked infarctions. So the huge thrombus, I done the 11 cases last 1.5 years. We have observed clinical follow-up. It is doing well, no problem, there no miss. Only one case is that the TLR, you have to do dilate the given one stent only. Any other experience and anything, please?
Yeah. Is this for Dan?
Can you answer that,
No,
Dr.
I'll answer.
Acute
Yeah.
MI situation.
Sorry,
Acute marked infarction.
Well, actually, there are very few data on that topic. In the beginning, the concern was that the presence of thrombus was limiting the transfer of the drug to the vessel wall, and that is a point of concern. Of course, even predil is a point of concern in thrombus-containing lesions. That's why in many of the DCB trials that was an exclusion criteria. But right now, there are many a couple of trials ongoing on this topic, and I personally am not a big fan of that subset of lesion to be treated by DCB. I like to treat with DCB long and diffuse disease. Otherwise, short lesion, as sometimes it is in myocardial infarction, to me it is not an interesting spot for this kind of technology.
Dan, do you have a short answer for that for you, since that was originally to you? Just the short answer.
I think there isn't any evidence. We do have case series. We have quite a young STEMI population. Often it's heavy thrombotic, not much in the way of atherosclerosis. So we have used DCB in isolated cases, but I think the evidence is low.
All right. Well, I'm so sorry. We'll take your question afterwards, sir. I'm sorry. We have to move on to, because otherwise we won't get through this. So our next speaker, hybrid strategy, learning from going beyond the conventional bifurcation techniques, the hybrid DEB study by Dr. Cohen Teowan. I hope I said your name right.
Yeah, it's Koen, but it's very difficult for everybody. So
How do you say
don't
your
worry.
name?
Koen.
Really?
Yeah.
Toon.
Koen.
Oh,
Yeah, it's
wow.
really Dutch.
Koen.
So,
No, but what about your last name?
you can also call me Cool. That's okay.
Okay, Koen.
Okay, thank you for the introduction and thank you for the invitation to this session. Today, so I'm going to tell you something about the hybrid DEP trial, and I'm going to give you some insights and also some cases. And this is a randomized, controlled, multi-center trial and registry in which we treat de-novo true bifurcation lesions with a diameter stenosis of the side branch of at least 50% at a diameter of 2.5 equally or more. So in the trial, we first start with treating the patient with a provisional one-stent strategy. We prepare the main branch, put in a stent, we do a pot, and then we leave it. And afterward, we evaluate the side branch, and if there's more than 70% residual stenosis or less than TME3 flow, patients will be randomized to a two-stent strategy, TAP or culotte, or a hybrid DEP strategy. So the primary endpoint is death, myocardial infarction, and target revascularization at 2 years follow-up. And now I show you some case how the DEP treatment is performed. So this is an 81-year-old male. He has a bifurcation lesion, Medina 100, with some diffuse disease also in the side branch. And first we prepare the main branch, we put in a stent, and then we do a pot. So then we evaluate the side branch. Well, and as you can appreciate, you can see that the main branch looks fine, but the side branch is still significantly stenosed. So we adhere to the protocol, unsatisfactory result, more than 70% stenosis, so patients will be randomized. So this patient was randomized to the DEP arm, and then we perform a pre-dilatation preparation from the side branch. And this is a very important point. You need to size the balloon according to the reference diameter of the side branch for several reasons. First, you want to create lumen and space, and this will prevent recoil and maybe occlusion. Second, you want to create tears into the intima media for local drug delivery of the MagicTouch balloon into the vessel wall, and it also enhances lumen gain at longer follow-up. So this patient was then treated with a MagicTouch balloon, and there was already an in-placed balloon in the main branch. You do the inflation for 60 seconds, and after this you do a kissing and a final pot. So this is the result, which looks very nice with less than 30% raised stenosis in the side branch. And this patient had a repeated angiogram at 12 months, and the result looks just fine. So currently we're enrolling about more than 250 patients. We're halfway. And yeah, these are some characteristics. Age 67, 50% stable angina and acute coronary syndrome. And predominantly a lot of LED lesions. Coronary imaging is about 90%, and it should be increased after the new recommendation of the EC guidelines. So we recommended it to all participating centers. Pre-dilatation in most lesions, and final kissing and pot should also be a little bit increased. So here's some procedural outcome, and I think the biggest challenge of this trial is how to cope with dissections, because dissections occur in approximately 90%. And this resulted in bill-out stenting about 7%, which is not too high if you compare it to other bifurcations studies, but the question is, do we really need that often a bill-out stenting? So in this image, you can see on the left, you can see a type A lesion, dissection. And I think nobody in the room would be reluctant to leave this. However, if you have a dissection like this, which is obliterating the lumen and where you have persistent contrast staining, then yeah, it becomes a little bit more difficult if it's more risk for occlusion. So what do we know? Well, we know from smaller DCB studies in the bifurcations that if you have dissections between type A and C, they will heal over 6 months' time. But these are small studies and a little residual stenosis. So now some cases. So this patient was treated according to the hybrid depth protocol. It is a complex bifurcation, a lot of calcium extending into the left main, side branch. So it was treated according to the protocol with an NC balloon 1-to-1 ratio. And this was the final result. So now my question to you in the audience. Who would do a bailout stenting for this patient?
So this is the question what I wanted to ask the last speaker. We can do a FFR and check.
FFR, you want to cross again with an FFR wire?
I am just asking.
Oh yeah, okay.
Because there are some over-enthusiastic operators who have used a FFR and shown that if it is normal,
Yeah.
you can take it out. But what will happen when the wire will be out?
Yeah.
And the Ginger trial, this is it is a non-invasive FFR. So I am confused that whether to believe a invasive FFR or non-invasive FFR in a DEV case. Here, stenting.
Okay, well, it's a good suggestion. You can do FFR measurements. Maybe over-the-wire FFR would be possible. I would not exchange wires probably because you create more dissection. Now, anyhow, yeah, sorry.
You can do just NC balloon for a long time, and pressure for 2 minutes, and wait. Sometimes it will heal by the balloon only.
Okay.
Without stenting.
Okay. Okay. Well, we left it. We pulled everything out, and the patient did fine. No events until now. Okay. So a second case. This is a Medina 101 with a high intermediate branch and a proximal LED. The patient was treated with a stent, performed the POT, and this is the result after the provisional approach. So you can see that there is still stenosis at the side branch, but also a little line of contrast. So it's type A dissection. So the patient was also randomized to the hybrid depth arm. He was pre-dilated. He got, again, a drug-coated balloon, MagicTouch, KISS, and a POT. And now you see this result. You see there's more dissection. The line is bigger. There's a little bit persisting contrast. So again, a question to the audience. Who would perform bailout stenting? No question. Who would perform?
Symptomatic ECG changes. We need to
Yeah, okay. No. Good flow, no ECG changes.
no symptoms.
No symptoms.
I'll leave it.
Okay.
I would have a hard time leaving this one alone, to be honest, and I don't have that much experience with drug-coated balloons. But this one, you see the staining. There's literally hardly any lumen there. The wire is keeping it open. I'd be worried.
Or at least one more try with a prolonged inflation, as you suggest.
Yeah.
Okay. Well, I don't have the answer as well, but we're gaining more data. But what did we did in this patient? Well, the operator decided that it should be treated with a stent. So he put in a stent. He wanted to do a tap, but there was too much protrusion in the main branch. So then he decided to do a crush. He crushed the stent, recrossed, kissed, and it was the final result, which looks fine angiographically.
You go home a little bit more relaxed, I guess.
Yeah.
Unfortunately, 30 months later, instant raised stenosis. Yeah. And now you're all going to tell me, yeah, but this should have been a culotte, because why did you do a top? It's a really narrow angle. Or you're going to tell me, yeah, well, this patient should have received a provisional approach from the left main to the diagonal first. But this is daily practice.
Yeah, but there's a lot of intimal hyperplasia inside the other stent, yeah.
And we might think we are all top players in our league.
Diagonal first is not a good option.
People talk.
Sorry?
Left main to diagonal is not a good option.
No, exactly. So we think we are all top players in our leagues, but from all the participants in this Congress, this is maybe a more representable image of ourselves. And taking this into mind, reducing complexity for bifurcation treatment probably leads to better outcome. And the hybrid depth treatment might be an attractive alternative to further improve outcome.
Stop at 20.
So one
question.
one slide. Very important, 1-to-1 ratio, ballooning, additional preparation if needed, and you will have residual stenosis. But usually you can leave it, and you will have dissections, and most dissections you can leave. Okay, thank you for your attention.
Thank you.
We can take one short question if anyone has. Okay, so from this trial, you have not yet learned about your predictors of side branch closure when you're treating with drug-coated balloon, but you're probably obviously going to be looking at that.
Yeah, exactly. Numbers are too low.
Too
We will
low.
look into it, but these are really interesting questions.
Thank you very, very much.
Thank you. So now, Dr. Chandra, please, he's going to present also some complex cases based on his experience. You're all looking forward to hear your interesting cases.
Okay, so you already saw various indications of doing drug-coated balloons in various indications, including bifurcation and osteal lesions, etc. So I'll directly come to some of the indications which we do today. So here you see there is a very tight osteal stenosis of the circumflex, and we know that these osteal stenosis behave absolutely erratically. Even if you put a stent, do whatever you want, these patients have very erratic outcomes. So you can see in this view also that it's a very tight stenosis of the ostium of the circumflex, and certainly it needs to be treated. So we did a pre-dilatation followed by cutting balloon, which is almost always. So in all these presentations you saw that we use Wolverine as the preferred cutting balloon. So after 212 balloon dilatation, we did a cutting balloon using a 2.75 and then did a 3x15 regulating balloon. This is the final result. So what do you expect? There is some haze there, but we said, okay, let us leave it. In the other view, it was looking all right. There is some minor dissection, but again, nothing to be done. So of course, these kind of cases, you do not want to put a stent here. So we left it at this. And then patient came with severe angina. And this time, the circumflex ostium is doing fine. There is a tight instant restenosis of the LAD. So you can see that, how they respond. These osteal lesions. So from now on, these days, our default strategy for any osteal lesion, whether it is LAD or circumflex, we do it with drug-eluting balloon and cutting balloon. Now, this is a patient who comes again with acute coronary syndrome with a previous stent in the proximal to mid part. And then, of course, we wired it, a lot of thrombus sitting here. We did some laser, to just do some treatment of this thrombus, and then dilatation, intravascular imaging to find out whether we dilate it further, the stent. And then beyond that, we started putting drug-eluting balloon with a 3x30 distally and then another 3.5 35. So these are overlapping balloons. All are MagicTouch, and we see this is a reasonably good result with some movement of the thrombus in the PLV branch, but we did some dilatation and left it as such. And this is a check angiogram at 1 year. You can see that the vessel is healed very well. There is and the lumens of these PLV, PDA, everything is looking quite nice. So this is the kind of healing we can expect at the end of 1 year many times, and then of course subsequently they will just remain all right. So there's the third case. You can see here that this is a patient again with a bad disease in the circumflex tapering vessel, and so here I don't think anybody would like to put a stent in this kind of a diffuse lung disease. So here and the right coronary was okay at that time. There was some disease in the ostium of the LAD. So we thought that probably we might have to put a stent there. So we did put a stent, but after treating the circumflex. So we treated the circumflex, and here you can see it's a dilatation with 2.5 balloons, cutting balloon, and then imaging was done to see whether we are at the right size. And although angiographically the vessel was looking 2.25, but we went with a 2.5 cutting balloon at high pressures, which becomes about 2.7. And then we took a long DEB here, starting from the proximal to the distal part, 2.540. And this is let me just show you, where is that? Yeah. So this was the result, looking reasonable. And The flow was okay, there was no problem, and this is after 1 year the patient comes with severe angina. So we thought that probably the circumflex should be the culprit, but here you see that the circumflex is absolutely, like grown like, full health, good health, but the RCA has gone this time, and RCA which was normal at that time. So, and this, of course, the LED is also doing fine. So this is the kind of expectation one should start having with these long diffuse disease also, where we use these long balloons, and especially for diseases like tapered vessels, etc. Of course, then this RCA which was the cause of the symptom was treated, and the patient did well after that. And then the last case is a primary PCI. Somebody asked this question whether we can do or we should do a primary PCI with DEB. Here we did. So of course, whenever we do this, we tell the patient, discuss with them that this is a new way of treating you, and if you are okay with this, we don't put a stent, and then of course the need of dual antiplatelet and of course long-term dual antiplatelet will be avoided, and most of the times they understand and agree. So this was a patient with a young patient in the proximal LAD with a bifurcation. And especially when there is a bifurcation lesion or a big side branch, we try to finish with the drug-eluting balloon because we don't want to jail these side branches. So here you can see that after the cutting balloon dilatation, again using Wolverine, there was a dissection over here, and then now we are using a 3x20 drug-eluting balloon. And after this, there was a haziness, there was some dissection, but we left everything behind. The flow was good. And after 1 year, this patient, when we did the angiogram, the side branch is pristine, nice, and the LAD is also healed up very well, and of course, no late lumen loss. So these are some of the real day-to-day cases where you can expect the outcomes to be, quite good and very effective with just 3 months of dual antiplatelet therapy.
Great.
Thank you.
Thank you, Dr. Chandra. Really, really impressive cases. Please go to the microphone if you have a question. Tell us who you are.
Thank you, Dr. Chandra, for your excellent cases. I am your fellow. And my question is, as we are in Southeast Asia like Bangladesh, India, whether during pre-dilatation with the intention of giving DCB, this balloon should be an N or it may be Ox?
So here, the most important thing is that it has to be a balloon which is a non-compliant balloon and should be 1:1, and preferably a cutting balloon. And for us, it is a Wolverine which works the best, not even the Scoreflex or the Angiosculpt. There are so many Score balloons, but we consider that Wolverine probably is the best in this situation.
And my next question is metal MI, meaning that he has previously stented and now come with acute ST elevation myocardial infarction. What will be the option? Whether you will put another stent, or in this case you will consider DCB?
Definitely not another stent, and here we will go ahead with again the same strategy and do a drug-eluting balloon. Of course, imaging is part of the whole thing now, and in our center we are about 120% imaging. Yeah. All cases undergo imaging.
Thank you so much. I think that we have to move. Oh, one more question quickly.
Any bad experiences of DEB?
Any?
Everyone shows about the bright side of the DEB. Any bad experiences with the DEB?
Not in this session. Come back. So,
yeah,
do you
but
want
let me tell you.
Do you want to tell the nightmares?
Yeah, let me just finish that.
Yeah.
That we have done approximately 1,500 DEBs and not a single case of touchwood acute occlusion in hospital. Thank you.
Okay. And do you want to share any of that example?
No, actually,
You did actually.
Yeah,
right?
I did already, and eventually stent was the problem. But I want to ask a question to Daniel, if it's just one last question. So we also see a lot of cutting balloon, scoring balloon, and C balloon. But what's for you your algorithm with the lesion you attack? Which device you choose?
Yeah, I mean, for me normally I usually start small and sequentially predilate, going up by sort of 0.5 millimeters to try and minimize dissection. I would usually use a 1-to-1 NC, and then if I'm not happy that there is any, as I like to have an element of dissection, so at which point I'll use a cutting balloon if I'm not happy that the NC's done the job, and again in a 1-to-1 before, and then use the DCB just to, it's the finishing touches. It shouldn't be used to modify the lesion. It should just be used to coat the vessel that's been predilated or prepared properly with the drug.
So the residual stenosis decides whether you progress.
Yeah.
But I have to say this, I have to agree with my friend Antonio Colombo, is that if you're not causing dissection, you're not doing a good job, because there will be a lot of recoil, and I think you have to break a little bit of the media so you also can have some drug penetration. So the fine line between what you leave behind, that's what the thing that we have to learn and more. Do you want to introduce the next?
I want to introduce, but I also think that in calcific diffuse disease, I really would find the use of, let's say, a arthroablative or plaque modification, and then followed by, because those often do give you some dissections, followed by drug-coated balloons could be really important, and it would be really nice to see those kinds of results as well. Thank you so much. I'm so sorry, we have to move to the next, and our keynote speaker is here, and we want to hear his thoughts, and we're really excited to have Dr. Alok Finn here to talk to us about sirolimus-coated balloon and CAD treatment. Why is it a better option, or is it?
I didn't know there was a
Dr.
keynote
Finn,
in this
you are the
presentation. Well,
You're the
how come
only one
how
who's
come I go
lecturing.
last? I don't go first. Isn't that where the keynote's supposed to go? Okay, so I'm going to give you some of the basics behind the MagicTouch balloon. We certainly know this balloon extremely well. We've done a lot of work with the balloon, and I can assure you I wouldn't have so many approvals for IDE studies in the United States if it wasn't a very good balloon. So I'm going to show you a little bit of the preclinical data. I think it's important for everyone to understand that preclinical work is really the foundation for moving things into the clinic. And as an investigator, you really need to understand a little bit more about its use in preclinical models before you move it into humans, because we can do more with preclinical models. We can see more, we can investigate more than you can ever investigate in a patient, and we can ensure that balance between safety and efficacy. And so in most cases, preclinical studies, we're looking at the artery that's been treated, obviously, but we're also looking at the downstream organs and other organs because of these particulates that are a big topic in DCB world, because all coatings, no matter which DCB it is, shed some particulate matter into the bloodstream, and that particulate matter doesn't always go to the artery treated. And DCBs are more tricky than stents. Obviously, they have to deliver a very high dose of drug overall because they're very inefficient in terms of drug delivery. That has to be rapid over the course of 30 to 60 seconds. And we need that drug to hug the wall, somehow get to the wall from the balloon. And so the diffusion of the drug has to be excellent. But overall, DCBs deliver drug in an uneven distribution. It's not the same as a drug-eluting stent. And really, the technologies themselves are very important in that delivery process. As we know for paclitaxel balloons, most of them are crystalline paclitaxel. And these crystalline particles are very effective in terms of biological effectiveness. They're retained over time, and there is drug effect over time, leading to effectiveness in terms of neonatal formation. But there's also a lot of particles released, especially with these crystalline paclitaxel balloons. And you can see here in an overall old study by Kelsch that was done with the contrast media or urea covering the balloon, that the efficiency of drug-coated balloons still remains fairly poor. We're talking about loss of balloon just on the surface, blowing it up, you lose about 40% of the balloon drug content at that point. A lot of it's lost during passage, and some of it remains on the balloon. So you imagine you might deliver 5 to 10% of the loaded drug, maybe more. That's it, probably. All right, so it's important to understand that the particles released by drug-coated balloons are all kinds of different sizes based upon the balloon. Here I've shown you different drug-coated balloons, and I've showed you examples under scanning electron microscopy of the kind of particulates released by mainly paclitaxel-coated balloons here in this size. You can see they're on the range of 100 to 400 microns in some cases. We say anything greater than 100 microns has the has the potential to obstruct arterioles and cause ischemia to downstream organs. So it's important you understand the particulate matter that's generated. The nice thing about sirolimus DCBs that I'll include in MagicTouch is it's in the sub-micron range of particulates, and I'll show you how we can prove that in animal models. You can see that the downstream embolization in the clinic, I'm often asked, well, so what? We lose a little bit of particulates downstream, who really cares? I think it's important to understand that slow flow phenomena and coronary flow reserve are both been shown to be impaired after using paclitaxel-coated balloons. So it shouldn't be dismissed as simply a non-important phenomena. And that's important, especially in places like below the knee, where we know wound healing, when you have slow flow, is impaired, and amputation-free rates are higher after slow flow. So these are areas where the particulates may be especially important. Now, the MagicTouch balloon is really uses phospholipid carrier with submicron particles to encapsulate the sirolimus. And so these particles are very well tolerated overall in the body, and they adhere well to the balloon and transfer well in terms of their transfer efficiency. And you can see here just a schematic of the phospholipid drug carrier. And these phospholipids actually have an avidity to the arterial wall. They transfer effectively, and then basically they're broken down over time by the body as they degrade. This was a study we did just showing you a little brief data on a randomized study in animals where we looked at POBA, MagicTouch, solution, or agent treated vessels, and we basically followed up the animals at 28 days after coronary angioplasty, and we submitted the tissue for histology. And I'm just going to show you the downstream sampling. This is what I mean why we can't tell these kind of things in human. Unfortunately, you cannot collect someone's heart after the procedure and section the heart, but in animals, obviously that's not a problem. And so you can look at different downstream territories and sample them. And you can see here, it's interesting that after you use a paclitaxel-coated balloon agent, you really have a lot of myocyte necrosis and scarring, whereas all the other balloons, the sirolimus-coated balloons, MagicTouch included, and POBA, don't cause any scarring to downstream myocytes at all, or myocardium. And when you look at embolic debris, the most embolic debris are generated by agent, as I would expect with those size of particles. So the MagicTouch, of course, is almost similar to POBA in terms of the amount of embolic debris it generates. And you can see here that on the histology, there are small particulates that are identified in the histology on MagicTouch as well as solution. You can see they're polarized light. You can see they come out quite clearly. But you can see with the paclitaxel-coated balloon agent, the scarring was much more extensive. And you can see areas of fibrosis as well as small arterioles where inflammation collects, which is likely due to embolic debris. Now, I want to just make one more comment. This is a different study. I'm presenting a different one that agent was used. And you can see what I want to just highlight in this study is we look at the same things. My important point here is that when you use more of the balloons, you use more agent, the more the evidence of emboli and the more the evidence of scarring. You can see it's a dose-dependent effect. So if you're thinking about using one balloon in the LAD, maybe it's something. If you're using 3 or 4 balloons, you need to think about the impact of those balloons on the downstream system. So in conclusion, paclitaxel DCBs are generally composed of crystalline PTX, which is efficacious, but poorly efficient and delivers lots of loss of paclitaxel non-target tissues. And that was really, I think we've shown this again and again. I don't think it's an issue of whether it exists or not. It does exist. The question is, what are the clinical impacts of those downstream debris? And it's really hard to detect in the clinic, obviously, but it doesn't mean it doesn't occur. MagicTouch really was very good in terms of, I didn't show you the data, but less medial injury and fairly good, no evidence of downstream scarring or and much less embolism. So I think that's very good. MagicTouch, I think, will continue to play. We saw some incredible cases that Dr. Chandra showed previous to this. I think it's bearing out to do very nicely in the clinic for both coronary and peripheral applications with the US IDE trials underway. So with that, thank you for your attention.
Very provocative. I think that's something that we have to keep in mind. Alok, and again, it's when we treat these patients, we don't think too much about distal embolization and microembolization. Do you think that we should design protocols to test new devices with those physiological assessments such as QFR, DFR, the ones that MicroPort is developing, Abbott is developing?
Yeah.
Do you think that's going to be complementary?
Alex, I think it's a great question. I think it's worth thinking about incorporating those kind of protocols into trials because certainly we do not want to impair the microcirculation. As you know very well, microcirculation is very important for the integrity of the myocytes and myocardium. So I think incorporating those kind of studies will also give us insights, Alex, not necessarily into an IDE study, but a comparative study, maybe which is a safer product. We can certainly try to prove that by comparing different products and seeing what their effects are.
Is there any clinically evident event following this microembolization, either of paclitaxel or sirolimus?
Yeah, so I would tell you that the biggest evidence of event, and it's not a cause and effect, is that no paclitaxel-coated balloon has ever been approved for below the knee. There have been multiple trials done, as you probably are aware, and none of them have been approved for below the knee. So we don't have an approved drug-coated balloon for below the knee. Now, why is that? I think partly it's due to the fact that the flow below the knee in these patients who are fairly sick is impaired. And so I'm showing you data from a very healthy animal, vigorous circulation, the best microcirculation you probably could get. Can you imagine? No patient is going to qualify for a drug-coated balloon with that kind of circulation. The circulation they have is much worse. And so when you're releasing particulates, it's probably likely it's going to get even more debris and stuck downstream than you saw in the animals. The animals are the best case scenario.
We have a great question from the audience, and I'm asking that from Alfonso. Is there a proposed protocol when you have a dissected artery after a drug-coated balloon in terms of reassessment of that artery, even when the patient is asymptomatic? What do you do when you see the dissection, the patient is asymptomatic? Are you bringing them back or are you leaving them? What are you doing? What's your protocol?
Well, in the beginning of the DCB era, it was common to call back the patient for angiographic follow-up at 3 to 6 months, but I'm speaking about, I would say, 10 and more years ago, while right now we have no protocol. We follow the patient just clinically. So if the dissection is a A to C dissection, so benign dissection, we leave it, and then we follow up the patient only clinically.
Any different opinion?
Additional comments?
Yeah, we don't have a fixed protocol, and but yeah, during getting experience with drug-coated balloons, at first you refer some patients back, but then you get more confident, and then eventually you don't call them back, but you also don't see them coming back. Mm-hmm. So I think that makes you more comfortable.
Yes, and the good news is that by next year we're going to have so much data from big randomized trials for TCT. We have all the solution series. From next year we're going to have Transform, which is 1,800 patients, and there will be some angiographic subanalysis, and I'm sure that these patients there will be a lot of scrutiny to make sure that these dissections, the angiographic dissections that we leave behind, are not going to correlate with worse outcomes. So I think that the data is coming, right? This is exciting. I think now with agent also approved by the FDA, there will be other studies, and very soon I think this question, Roxana, will be answered. And meanwhile, I think we should follow some of the guidelines, the consensus that you and I and many others wrote, and it's going to be published at EuroIntervention and submitted to JACC Intervention. So I think that we're going to have some guidelines based on a consensus what to do with residual stenosis and dissections. You want to conclude?
Yeah. So first of all, a fantastic session. Thank you for presenting some of these really challenging cases and beautiful lessons learned from all of the clinical trials that you're all doing, but also sharing some of your own experiences. It's really interesting. Drug-coated balloons have been around forever, for a long, long time. We certainly, just in the United States, we're always behind the times, especially these days. But we're now literally using them now in clinical practice. Unfortunately, it's way too expensive for us to use it on a regular basis, as you guys have, but also importantly, in de novo lesions, and not understanding why would we not just stent it. You heard some aggressive questions with regard to stent thrombosis. Well, it wouldn't be stent thrombosis because there is no stent there. But actually, the thrombotic occlusion is something everyone is afraid of. So we learned a lot, and we continue to learn. And all of the clinical evidence and the data are coming forth for us to learn even more. The differences between sirolimus and paclitaxel, I think, is very, very interesting. But until we have head-to-head trials, we can't really be doing cross-trial comparisons. And I think this is also very important. But what I learned most from this is that this idea that, oh, you drug-coated balloons are never going to work in the coronaries is over. That's a past era. There is no question that this particular device is needed on all of our shelves, in every hospital for pretty much every situation. And I think that to have them in our cath lab is going to be extremely important. The type of drug-coated balloon and what you can do with it, I think, is something that we learned a lot. Today, we learned a lot of the data from the MagicTouch balloon, and I think they're pretty impressive, and we await the Transform and multiple of the studies. But certainly, to me, it looks like sirolimus-coated balloons are working here, but we need still the evidence. So thank you so much for being here. Thank you all for your attention, and thank you, Dr. Finn, for your wonderful lecture.